The content of this podcast is for informational purposes only and should not be considered medical advice. Always consult with a qualified healthcare professional for any health concerns. Take care of yourself out there.
Welcome to Unravelling. This is a podcast that sees the world through the lens of mental health. I'm Mary Wilson, a journalist.
I'm Kurt White, a social worker and psychotherapist.
And Kurt, today we're going to be talking about challenging the status quo when it comes to the mental health system and how there may be some limitations with the mainstream system. This is something that you came across very early in your professional career.
Oh, yeah, absolutely. I think that probably all systems have limitations, and I think healthy ones are systems that are striving to be better than they are and listening to critiques from in and outside of the field, but especially to those who are critiquing it from a perspective of lived experience. But in my own professional life, I started out doing work in the field before I went to graduate school as a case manager in another state in a place with that was a long-term care facility for people with severe and persistent mental health problems like schizophrenia diagnoses and hearing voices and paranoia and things like that, and that weren't necessarily by most measures, doing very well, living independently. So they were living in this kind of large 200-person congregate living situation that was an old hotel. That was a hard place to work.
Why was that?
It's, I really started to see that although the staff were really wonderful and caring people, the system that people's care was embedded in was really not interested in understanding what the world was like from their perspective. It was interested in kind of laying down on top of them almost, like a mental health treatment system that said, what you need is this kind of thing. You need a medicine. You need to get a job in a sort of factory to get better, psychosocial rehabilitation. You need this, you need that. And I really saw people not necessarily doing very well with those interventions. They weren't changing very much. They were suffering a lot, I think, both from their symptoms, but also from a world that didn't really value their participation in it.
So they really were being left out of the conversation about their own care and not being included in that dialogue.
Oh, yeah, absolutely. And I think that happened both in sort of gross and subtle ways. And at the more subtle level, I think there's this idea that sometimes the mental health system in general is not so interested in the perspective of illness or the perspective of experience, maybe we should really say, that comes from the person that's actually having it. We instead have our own expertise. We have our own ideas about it that we try to sort of steer people into a treatment system that makes sense from our perspective, right? And there's an analogy there to that's kind of how medicine works, right? If you have a back problem, maybe you get physical therapy, and then if that doesn't work, maybe you get some injections, and if that doesn't work, maybe you get a surgery. And you sort of have to move through the system the way the system is laid out for you. But maybe mental health isn't like that in the same way all of the time.
You were witnessing really the failure of this system, and what was that like for you as someone working as a part of it?
I did come to see it as a failure, and I even experienced it in a pretty significant way as eventually a kind of a burnout that took me over almost. And I would think about this work all of the time. I would feel just incredibly sad, sometimes very desperate even, that people were not really taken seriously as individuals, as human beings. Their sort of expertise in their own lives, even with mental health problems, wasn't really valued in a meaningful way. And so I went to graduate school, and normally you arrive in graduate school, people think, you're an idealistic young person that thinks they could change the world. I really didn't think that. I thought I probably couldn't do much of anything at all. I thought something is wrong somewhere career, and I feel very sort of depressed about it, professionally depressed, you might say. And I was giving it a go, but I wasn't really sure that anything was going to be able to change that.
But you realize that people are working to reimagine the system and look at things in a radical way.
That's right, and that was a great thing for me, to learn what I don't know about what I don't know. And I encountered, a number of different kinds of ideas that had changed my perspective on things and kind of got my internal spark going again. But one of them, in particular, stays with me, and I've never really stopped thinking about it, even though it's not the model isn't exactly what I do every day, but the way that it has influenced me, has influenced so many things in the way that I think about things, that it has stayed with me. This is the work of the open dialogue model, and in particular, Jaakko Seikkula, who's one of the founders in that model, and someone who helped to develop and research certain perspectives on the mental health system over a period of decades.
And we got to speak with him.
I'm so excited for that and to share this interview with everybody here, because I think we can really start to learn some different ways of thinking about some ideas about the mental health system that we don't question often enough.
And Dr. Jaakko Seikkula is a clinical psychologist, a family therapist, researcher, retired professor in Finland with over 40 years of experience in clinical research and teaching. He's a founding member of the Open Dialogue approach. He's been a lecturer and trainer in Europe, Asia, and America, and has more than 190 published articles and books on the principles, practice, and evidence of the Open Dialogue approach and dialogical practices in mental health. He's also won awards for his research career at the European Family Association and the American Family Therapy Academy. We got a chance to speak with him, so let's listen into that interview.
Well, Dr. Seikkula, thank you so much for joining us on Unravelling.
Thank you for the invitation. It's a pleasure to be here with you.
I was really interested to talk to you about your work over the course of many decades and the interesting way that the ideas and practices that you've come up with have been influencing the field. But before we get into a lot of that, I wonder if maybe you could just tell me about what was your training like before all of that, when you first got into the field?
As a background, I'm trained first as a clinical psychologist, and then I've specialized in family therapy, and thereafter doing a lot of research, so that my career was mainly in the university, professor in the university, as a professor in psychotherapy.
And what was it about that initial work that drew you to this work in open dialogue and that you helped to create? How did you move from the one thing to the other? I'm sort of interested in that part of it.
Well, when I started to work as a clinical psychologist, from the very beginning, I had an interest of the most severe mental health crises and problems as psychotic problems and any other kind of crisis. And I looked for a job working in the psychiatric hospital or in the psychiatric outpatient care. And step by step, after a few years working, I went to Lapland in Finland, in Tornio, in which there was a small psychiatric hospital that was on the way to develop from a place for people who had chronified into their situation into an acute care system for the local people. And we were very lucky because we were a very small team and all of us seemed to have the very same interest that we want to develop something new that we called as family-centered care. We really wanted to have place for the families to enter the idea, and that was the starting point, so that I myself had an interest to having individual psychotherapeutic relationships with people who may have had long time psychotic problems, and at the same time we developed this practice in which we started to invite the families. And after some attempts in the beginning, now I'm speaking of some year 80, 81, 82, we tried to apply ideas of family therapy as a part of the plan of care that we made for the people who had been hospitalized, and we were not successful in that. We realized that very few families could be part of that, and we were looking for options. And at that time, we met with an idea that originally had been developed by Professor Yrjö Alanen, who is a very, very known person in Finland, based on the idea of developing something that is called need-adapted approach, an approach that always adapted to the unique needs of every client. And in that moment, we met with the idea of open meetings 1984. And when we met the idea, we immediately revised our work in the way and started to have the open meetings idea in the care. Open meetings in the way that we gave up meetings among professionals, and we always invited the one who had been hospitalized, and always also the family, without an idea that we need to have a family therapy, we need to change the family, but actually the opposite, to invite the families to help us.
That's a pretty radical idea, isn't it? To really have all of your conversations about somebody with them present. What was it that led you to want to do that?
It's really radical idea. Even now, 40 years after, it seems even more radical now than it was at the time that we did it. I think that one basis was a kind of psychotherapeutic interest that we all had. At that time, when the staff was meeting, even if having a psychotherapeutic idea, there was an idea that you need to have conversation in a secret, to use all your knowledge to define what this is all about. And the first surprise to us was that we immediately realized that it's possible to speak into the open all the issues that we thought that we only can speak amongst the staff, if we only learn a bit more polite way to speak about the situations.
Can you give an example of that? I'm interested in what that looks like in practice.
Well, first of all, these open meetings are organized in a way that we as professionals, we do not plan, we do not make any preparation for them. But it's really important that we come into the room by the same door opening, sit down and start to discuss. And then second point is that we also work as a team, that there is not only one doctor, one psychologist, psychotherapist, but we are there. Doctor, psychologists, nurses, all who were involved in this helping the clients. And then we invite the people to say, how are you? How would you like to use the time? And the idea is to follow their stories without an idea that we have some agenda that we would have defined to us in advance, which we think that this is the point into which we have to make an intervention. We follow the stories, the ideas, and accept those without any conditions what people want to speak about, and make our answers and comments to that. We also are transparent in our work so that we all the time can comment to each other. How do we feel? How do we think? In respect of what kind of plans of care do we need to take, but also a bit more profound ideas. How do we feel about the issues that the father spoke about, the sadness that he has had? And it seems that this kind of conversation among the professionals really increase the space for the clients in crisis to look at their lives. And they have perhaps a bit more security to get closer to the ideas that they perhaps have tried to avoid to do that. But I think that it's all the time so important that we do not do any judgment, we do not do any interpretations, we do not give meanings for that, but the only idea is to follow their speaking.
To follow their speaking. And that's true, just so people understand that this is also, you're talking about working with people maybe who are having active delusional, what we'd call delusional ideas,
Exactly.
or hallucinations or paranoia, some of the most significant mental health symptoms. Is that right?
That's right, yeah. And of course, those maybe are one of the most challenging point of views, because you can easily understand that within a family in which one has a strong feeling that in TV they are speaking about my life in this soap opera, and all the rest of the family are so fed up with that. Stop speaking like nonsense like this. This is not true. That there are so many different opinions about it. And how do we manage to have a way of speaking, have a way of dialogue in which all those voices are heard? As for instance, 2 weeks ago, we met with a family who all of a sudden that I want to live in Australia. Oh, you want to live in Australia? And it happened during this meeting that the mother afterwards she wrote a letter and said that this was so strange because in this meeting everything changed in her life. She only has been looking at that how what is this crazy thought about Australia and everything. And my daughter is so ill and she needs medication. She needs perhaps put into the hospital and she do not speak. But in our meeting, she started to speak more and more openly. And the mother wrote that I started to listen to her. And I think that that is perhaps the best outcome.
And I've noticed that very often, at least the system that I was trained in, a sort of American mental health system, the more significant your symptom, the less interested people are in listening to your meaning making about it.
Yes.
Have you noticed that also?
Yes, and it's terrible.
Yeah.
I got emails from all over the world all the time. And people write about the misuse of power to them, and they write that they didn't listen to me. The doctor said that you have something going on in your brain. It's like it's very toxic. It's like you had a cancer in your brain, and you need to stop this by using medication, and you probably need to use the medication the entire life. And what is this kind of response? It's a stop of use of any own resources for the recovery. And this open dialogue idea is a definite opposite. The only idea is to mobilize their own resources, which they have in their relationships, in their family, in their own reasoning, and using their own creativity. Whereas this traditional view is that you are so ill that you need to be taken care of and you need to follow the rules of life to prevent relapses without any idea that you could use your own creativity or.
I like this word creativity. It's not one that comes up a lot, I think, in terms of, especially working with intense symptoms like that, or maybe even in the mental health world at all. And I wonder if you could say a little bit more about what you mean by creativity, and maybe how you've seen people find creative solutions to problems that maybe professionals wouldn't have found, for example.
It's always so unique. In one story with a young lady, it was part of the studies also. We had a follow-up of 5 years. And in this 5-year follow-up, the mother said that when 2 years had passed, she was so concerned about her daughter. She seemed to be very depressed and she couldn't do any initiative by herself. Then it happened that it was summertime. Their house was nearby the highway. And many mornings, the daughter took a walk to the highway. And what she saw was people biking. And all of a sudden, because she had a history of athlete, she came home, packed her things into the bike, and took a bicycle ride from Finland to Spain.
Oh my gosh!
It's a very long. It's a very long trip. Yeah. And she was on this trip a bit less than 2 months. And mother said that when she came back home, she had totally changed. And this was, of course, a very extreme idea. I don't think that she biked all the way. She used train and everything. But still, the idea that I need to do something in my life. And during that trip, he had regained a kind of mastery in her own lives.
So one of the hallmarks of this way of intervening is to involve people's families and systems in the treatment as real essential participants. Is that right?
Exactly. Yeah. I think more and more about the idea that our human mind lives in relationships. We are, in a way, constructed from relationships, relational experiences, and it's so important that our interventions in crisis are based on this very, very basic understanding of human life, how to be in relationship, how to take use about the relational experiences what people have in their families, even if they may have had bad things in the families. We need to find ways to do that.
One of the things that I was, when I first heard about this model back when I was in training over 20 years ago, that intrigued me so much was the idea that there were certain principles that you were working to apply in intervening. It's almost like it's a change to the system that then affects the individual in a different way. And I wonder if you could speak about some of those principles and how they differ maybe from the ways that we're used to operating maybe in a traditional Western mental health system.
The first step towards new system was to realize that we need to have place to have the meetings with the families much more earlier than we were used to have in the hospital. And then we reorganized the system that everyone who had a referral to the hospital had their first meeting with the team and hopefully with the family before the final decision was made to hospitalize. And what happened, that was also a basis for our first large research project. We found out that 30% of the referrals could be dissolved in this first meeting if the team took responsibility to organize the care by going homes. And thereafter, we reorganized the system in our small province, organized mobile crisis intervention teams. And when this has been going on some years, we made an analysis to look at what are the optimal elements in this new care of having mobile crisis intervention teams meeting with families. And then we came up into this as a conclusion of the analysis of these principles that the optimal idea is that you really need to have the first meeting immediately within the first day after the contact, within the first 24 hours after the contact has made, because in this way you meet people in the emotional turmoil, and that's in this emotional experiences the new resources are living. Second point is that you always need to invite the family and many times also the other part of the social network to really create this relational context. The third point is that you always need to adapt to the unique needs of everyone, being flexible with the methods of care that you use. Someone needs medication, someone less, someone needs to be hospitalized for a suicidal threat for some days, someone can take advantage of individual psychotherapy, and all these methods of care are used in this new idea. The next point is that the team need to take guarantee responsibility, being available for the families from the very beginning, but also throughout the process, and guaranteeing the psychological continuity in the way that you need to work across the boundaries in the service system. Many times you need to invite social workers. Perhaps in the family there is a situation with the kids and with the adults, and how to work with the services with the children and the adults, integrate them to the meeting. And then the final point was that by so doing, by these concrete elements, you need to increase safety, that we can tolerate the uncertainty that the crisis is creating and avoid going too rapidly into the conclusion and solution. And that's why we need dialogues. So it's actually a question of 2 points. We have some, it seems to be good follow some basic rules to organize the system of care. And then the second point is to focus on dialogues in the meeting, because in dialogues people have the feeling that they are respected and listened to, and in that way they can mobilize their own resources.
Mm-hmm. And I'm interested in a lot of the research that you've done has had to do with so-called first episode psychosis, when people first begin to experience symptoms like hallucinations or delusions or paranoia, often in a crisis way, and that often emerges in adolescence or early adulthood. Why the special attention to this particular time of this problem emerging?
I think that in this kind of experiences, perhaps this idea that you are dealing with some experiences that do not yet have words is most present in the idea, and you are meeting with, or you are living in a way, in a very extreme stress situation in which there may be several stress factors, not so much being aware of them. Perhaps you may also be aware of them, and step by step things go into the way that you no longer have any other way out than going into a kind of world that is a bit illusionary, and that's something that we need. It's nothing bad, because if you are in an extreme situation, this is a way to protect us. And it's so important that we professionals understand that this is a kind of a psychological or very embodied psychological response to, to something that has happened, even if we do not know what has happened, instead of thinking that this is a pathological situation in which we need to take intervention for the symptoms. And if we do that, everything goes wrong. Then the people start to be chronified of the ideas. And I think that in our studies, based on the outcomes, they are very different. They are really different compared to the mainstream results in psychotic crisis.
And I think there's maybe a risk for some people that they might think, oh, well, there's just something different going on in that part of the world, But actually, the mental health system in most of Finland was traditionally much like that in Western Europe and in America, isn't that right? And
exactly,
with those kinds of Western negative outcomes for this kind of problem.
Yeah. I think that the big mistake happened early 90s when this evidence-based idea, especially when there was this treatment guidelines for schizophrenia, was created, that focus on this, that this is a brain illness and you need to get intervention for the symptoms, and the outcomes are worse now than they were 30 years ago.
Oh, that's interesting. I hadn't heard that. Really, actually worse than they were before.
Yeah.
I mean, I think sometimes, people in my world that know about open dialogue are often very inspired by it. But I think sometimes even those that are inspired by it, it can feel almost like it's too good to be true. That could it really be that if we could transform a system just based on a series of things that seem very doable on the one hand, a way of approaching people, a way of thinking about crisis differently. Do you think that if other systems could adopt this, that we really would see outcomes like the ones that you've had?
I think so, yeah. And my interest during the last years has been that we also have been pretty successful at creating a kind of global network for supporting people who have an interest for more humanistic practices. And we focus of organizing training programs, because you really need to have a kind of mental resources in this new approach to meet with human instead of taking interventions to the symptoms. And this has happened in many countries, and I really have seen that it happens in different contexts, and professionals are very surprised that when they see that really a new way of working is possible.
Mm-hmm. What would you say maybe to practitioners who are inspired by this work but not in a position to change the system, or maybe even to have advanced training in open dialogue, if they were to change maybe one or two things about the way that they approach the people they're working with, what would you suggest they do?
I would suggest, if possible, to when you meet with people in serious crisis, please invite your colleague with you. And if possible, if the financing system and other things allow, it's so much more powerful. And when you meet with the people, please start to listen to their stories without an idea to change them, and encouraging them to tell stories. And if you do that, you immediately see the difference. You may be surprised.
without an idea to change them.
Yeah.
That's very powerful. Well, Dr. Seikkula, I'm really inspired by this conversation today. I've got to tell you, it's a real honor to talk with you. You're a person who's been a bit of a professional hero to me, and I've been following your work quietly for over 25 years or something, as I've done many other different things. But it's a real honor to talk to you.
Thank you once again for the invitation, and I'm so happy that you deal with these issues, and I wish you all the best. Good luck in your efforts.
So joining me again is Mary. Welcome back, Mary.
Thank you. It was a really wonderful interview. So interesting to hear this different perspective. And I know you came across Dr. Seikkula's work so long ago, and you've been in mental health ever since. So how do you keep some of these concepts in your mind as you work with people?
Yeah, well, I think he had a lot of wonderful things to say about that. I think the spirit of it for me, I think, is of really trying to understand the person that you're working with as the true expert in their own life, to really approach any effort at helping with intense and ongoing practices of humility, and of really trying to listen in this way that he talks about. I think probably it's easy to fall down on the job with that sometimes, to start to think of yourself as the person who really knows things, that has the answers, that's the expert. And maybe actually it's just when we start to think that we're actually losing the person that's with us and the meaning that they're making of their experience.
It sounds so simple, just listening to people, but it can be quite challenging.
I know, right? And sometimes our training helps with that, and maybe sometimes it actually gets in the way. And I'm really grateful to people like Dr. Seikkula and others who challenge us to think about things in very different ways.
And be sure to join us next episode. We'll continue this conversation and hear from someone who is speaking about peer-led alternatives to our mainstream mental health system.
I can't wait. Unravelling is brought to you by Brattleboro Retreat and is produced by Charts and Leisure.
Find us on social media by searching Brattleboro Retreat. Brattleboro Retreat is committed to exploring diverse perspectives on mental health. While we invite hosts and guests to share their insights, the views expressed are their own and do not necessarily reflect the policies or positions of the hospital or its staff.